Welcome to the Boomer Buzz, the show that focuses on issues of interest to the 60 and over crowd, both here on Long Island and across the country. Listen as experts keep you informed about the latest health solutions, financial options, and lifestyle choices, both for senior citizens and their families. Now, here are the hosts of the Boomer Buzz, Dr. Lamar Stanford and Patricia Stanford, corporate wellness consultant, on the voice of Nassau Community College, 90.3 WHPC.
Welcome to the Boomer Buzz, where each week we'll give you the buzz on how to stay healthy, wealthy, and wise after the age of 60.
Today we're speaking with neurologist Dr. Luca Giliberto from the Northwell Health Center on detection, treatment, and prevention of Alzheimer's disease.
Welcome to the show, Dr. Giliberto.
Thank you. Good evening to everybody.
It's an honor to have such a knowledgeable authority on Alzheimer's disease speak with us today. First of all,
thank you.
A lot of us are calling a lot of different things Alzheimer's disease, and we're kind of lumping dementia and Alzheimer's together. Are they the same thing, or are they separate diseases?
Yes, that's an excellent point. I do receive that question pretty much every day from family members of affected individuals or concerned family members. Alzheimer's disease is one type of dementia. Alzheimer's disease is a neurodegenerative disease where the brain cells, the neurons, tend to die, amongst with many other different changes in the brain. But dementia is a more general concept. Dementia is a situation, it literally means without mind, from the Latin. It is a cognitive situation where one loses their ability to remember things, to reason, to use objects, to speak or understand spoken language. And it gets to a point where they're not able to perform actions of daily life. They can't write, use the computer, use the phone, or even cook, or even open a door at the extreme. And this is a change from the prior level of function. These are somebody that used to work, go around, drive, and then gradually they can't do that anymore. That is the definition of dementia. Alzheimer's is one cause of dementia. It's the most frequent, probably the most spoken of, but there are many other causes of dementia. For example, vascular disease of the brain. That is a very, very important cause of dementia that's very frequent. It's number 2 in the list, and often overlaps with Alzheimer's. Often we do have patients who have both conditions. They do have strokes, they do have vascular disease of the brain, but on top of that there's also Alzheimer's pathology. Other causes of dementia can be Parkinson. Parkinson does come with degree of dementia eventually, can progress towards dementia. And there's several others, neurodegenerative diseases of the brain, like frontotemporal lobe degeneration, Lewy body disease, and so forth, that will eventually lead to dementia. They're all very different. The presentation is very different. The pathology, when we look under the microscope, is very different. But they result in an inevitable loss of cognitive abilities and loss of function. So that's the key differential. Alzheimer's disease is one of the many types of dementia that one can have.
Okay, so with Alzheimer's, how common is Alzheimer's disease as opposed to dementia? Are there statistics on which is a more common disease? Well,
again, dementia is the general clinical definition of what happens when a patient loses the cognitive ability. Alzheimer's is the most frequent type of dementia. So I would say 65-70% of people who eventually present dementia have Alzheimer's pathology. Number 2 is vascular dementia. Number 3 is Parkinson-related dementia, frontotemporal lobe degeneration.
Okay. Now, can I just ask you a question, Doctor? We hear about the tangles, or I don't know the specific name for it, but when they have Alzheimer's, their brain has these tangles that develop in their brain. Is that a pure Alzheimer's presentation?
So, yes, the pathology of Alzheimer's has been described now for 100 years or more, and we have come to understand it more and more in details. There's 3 major items in the pathology of Alzheimer's disease. One is the accumulation of a protein called amyloid, and it builds up in these so-called plaques, amyloid plaques, which I think a lot of people have heard about. Number 2 is the accumulation of these tangles that you were talking about, and they're made of a different protein called tau. And these 2 lesions accumulate gradually in different parts of the brain, and there's a specific topography, so each one of them prefers different areas of the brain, but then eventually with progression they all come together in a very big confluence of pathology. And number 3, neuronal loss. So the nerve cells that make the brain what it is, the thinking machine that it is, these brain cells just die off. They disintegrate, they disappear. There are some other minor features of pathology in Alzheimer's disease, but these are the main thing. The tangles you're referring to are very, very important because the percentage and the location of these tangles are proportional to the degree of cognitive loss. So the more one is forgetful, the more tangles one has. So that type of pathology, this tau pathology, has been the focus of much more attention in the last few years for different reasons, because we know it better now, it's much better characterized, and also because while 20, 30 years ago we used to focus much more on the amyloid pathology, and we have tried to come up with treatments against this amyloid pathology. Well, those treatments did not work so far. A lot of the trials that have been targeting amyloid pathology have failed, and so the scientific community has shifted a little bit towards tau pathology to see if targeting this may be beneficial.
Just a question about the progression of Alzheimer's. You gave us 3 different types, the amyloid, the tangles, and the nerve loss. Is that the progression of Alzheimer's? In other words, do they start off with just very few amyloid plaques, then they go to the tangles, then the nerve loss? Is that how it progresses?
In general, yes. In general terms, yes. But it has been very challenging to link amyloid to tau and to nerve loss. At a certain point, everything coexists. Every lesion coexists with each other, but there is there's some lines of thought that amyloid will cause tau pathology, and that will eventually cause the neuron death. Not everybody agrees with that, and I happen to be one that doesn't really not agree completely with that hypothesis. And unfortunately, we don't know how things work exactly. There can be early neuronal loss even with very little amyloid or very little tau pathology. So this is still grossly debated. But in general, you can say that is the trend of what happens in the brain of Alzheimer's disease.
And how quickly does this disease progress? Is there a way, once a person is diagnosed, is it something that progresses quickly? Does it take years for these, the complete memory loss?
Like President Reagan had his Alzheimer's disease for 10 years before he passed on. Is that typical?
Yes, so the disease, it's very interesting how the pathology progresses, because we project that the pathology is present in the brain decades before one presents the clinical symptoms. In other words, if somebody's diagnosed at 65, we can assume that there is pathology that has been brewing around for maybe 20, 30 years. This is based on pathological studies, familiar cases, animal models, and even cases of Down syndrome, which is very interesting because in Down syndrome, there's a tendency to produce a lot of amyloid because of the genetic defect. These patients tend to have accumulation of amyloid and tau and have Alzheimer's type pathology very, very, very early, even in their 20s. That is one feature, the fact that the pathology has been in the brain of these patients for decades before we even notice any slight memory defect. Now, how does it progress as we go along? Well, it is typical to start with forgetfulness. So I'm losing my credit card. I'm forgetting that I went to the restaurant last night and what I ate and so forth. But the presentation can be different, and especially when the onset is earlier, maybe in the late 50s as opposed to the 70s, the presentation can be different, can be not just forgetfulness, it can be personality changes, it can be the inability to sustain a conversation, to think straight, to analyze problems and solve them. So the presentation can be very different, and one may not realize that that is Alzheimer's disease until many, many years later.
It almost seems like there's nothing we can do to prevent the onset of Alzheimer's, is there? That's
correct. That is also a very tricky field because there's a lot of rumor about diets and other things and supplements and so forth. Certainly there is no medications currently, FDA approved or in the research pipeline, that is very promising to stop the disease or make it go back. We are testing many different medications, and in the research field, we are working a lot with antibodies that attack amyloid or tau, but so far we haven't had great results. We're awaiting results from tau antibody clinical trials, but again, it's a little early to say if they work or not. We're crossing our fingers for that. In terms of prevention, so to something you can do in your 20s and 30s to prevent Alzheimer's, well, I think we're still very far. We don't have a lot. The only intervention that has proven beneficial in preventing dementia in general, but possibly also Alzheimer's disease, is exercise. Any type of exercise, and I would add that not necessarily the more the better, but the variety, the most variety, the better. So not just aerobic exercise, but even strength training and weightlifting. So a combination has been proven over and over and over again to be beneficial on the brain. And this touches many different physiological pathways, including the removal of these bad proteins that accumulate in the brain, the fact that people who exercise have a better cardiovascular health, and so the vascular pathology, which would make Alzheimer's worse, doesn't do that. So if you're in good health, you have less vascular pathology, less cardiovascular issues, and Alzheimer's pathology will not thrive as much. It will be slower to progress.
Yeah, that makes sense.
Okay. I'm Patricia Stanford, corporate wellness consultant, along with my husband, Dr. Lamar Stanford, and our guest today is Dr. Luca Giliberto from the Northwell Health on the detection, treatment, and prevention of Alzheimer's disease. You are listening to the Boomer Buzz on the voice of Nassau Community College, 90.3 WHPC. So, of course, I think a lot of our listeners are probably thinking about all of the times that they have lost their keys or can't find their purse, in the case of women, the wallet in case of men, and all of these other things. So, how is the disease diagnosed if somebody is having issues with forgetfulness and decide to come to a neurologist's office? How would you diagnose?
So it is very common at a certain point to lose your keys. So I would discourage anybody to think that they have Alzheimer's because of that. I cannot name how many times I have not found my car in the parking lot because I get there in the morning and by the time I get out, I have no idea where I parked it. So that happens to all of us. It is important to differentiate between a physiological forgetfulness and a forgetfulness that can happen as we age from what seems to be Alzheimer's disease. Now, let's start from the end. The definitive diagnosis of Alzheimer's disease is only done by pathology, by looking at the tissue, so post-mortem or if you do a biopsy. And there's a possibility of doing fancy diagnostic procedures such as a PET scan to look for this amyloid or tau protein. So this is live imaging where you do a specific scan. It's elaborated, it's very expensive. Insurance companies will most likely not pay for it, so it's mostly done in the research environment, and you can have a definite diagnosis. There's also a spinal tap to the collection of spinal fluid from the back, which may help, not 100%, but may give good indication if one has Alzheimer's. So those are the ways to diagnose it in a definite, like 100% type of way. But most of the times we rely on a possible diagnosis or a probable diagnosis. The first step is really to get the patient into a neurologist's office, hopefully somebody that does this on a regular basis, has the experience, and trying to understand exactly how the problem started. It's very, very important to have a good history on how things have started.
Does that mean that if your father had Alzheimer's disease, there's a good chance that you may have it? In other words, that history is really important?
History is important, family history is important, but the familiar cases of Alzheimer's disease are only related to the very early onset cases, meaning if people have Alzheimer's disease in their 40s or 50s, and in every generation you have somebody that has that, then you are at high risk, and then it would be warranted to look for genetic causes of Alzheimer's disease, which are pretty rare. There's only 3 genes that give genetic Alzheimer's disease, and it's only about 5% of the cases of Alzheimer's disease. The vast majority of Alzheimer's disease is a late onset, sporadic. It means that if your father had Alzheimer's at 70 years old, you're not significantly higher risk of having Alzheimer's disease. And that's because Alzheimer's disease is so frequent, it's so diffuse in the population that pretty much any family you can find somebody with Alzheimer's disease. There are some genetic variants which don't give 100% chance of getting Alzheimer's disease, but a probability of getting it, which we don't use routinely in clinical practice. And again, they're mostly used for research purposes. The first step is really understanding how things have started, making sure there's no medication that are sometimes involved in reducing our memory and our performance. A lot of medication that the elderly patient take are causing memory problems. Medication for prostate and so forth. Antidepressants can do that. Antihypertensive can do that. We then examine the patient. We do cognitive testing. We test the memory. We test the speech and all the other cognitive function. We get imaging of the brain, which is an MRI, most important, better than the CAT scan. If it's possible to get an MRI, I usually get an MRI. And that gives me an idea of the pattern of atrophy of the brain. So how's the brain shrinking? Is it getting smaller? And in which areas are getting smaller and they don't look good? Also, the MRI allows me to rule out other issues, for example, the presence of strokes. And as I said earlier, strokes is the other major cause of dementia in this population. And by the MRI, I can also see if there's presence of tumors or other pathologies that may give dementia or memory problem.
Can I just interrupt you for a moment? I recently had a stroke in my cerebellum.
Ooh.
And so, does it depend where the stroke took place, whether you have a propensity towards Alzheimer's, or do you think I should be watching out for that?
Dementia.
Yes. So strokes, it's interesting because the cerebellum is a very underrated organ, but there are cases of cognitive impairment and dementia from cerebellar strokes. The vascular pathology could be either a generalized vascular disease, like you have in chronic hypertension, and you have a general white matter microvascular disease, or you can have strategic strokes. So strokes that happen in specific areas, which, very unfortunately, they hit the area that controls your memory or your speech. Mm-hmm. And there you have it. One stroke is enough to impair you. For example, the anterior thalamus, if you have a stroke in the left anterior thalamus, well, you're probably most likely going to be demented, or at least very forgetful. So it is very different. It really varies on the location, yes.
It sounds like there is no absolute cure for Alzheimer's. It's a question of managing the downward progression. Is that correct?
Yes, unfortunately, to date, we don't have medications to stop the progression or even revert the problem. As I said, the approved medication that are currently in the market for Alzheimer's, for treatment of Alzheimer's, are symptomatic medications. They improve the symptoms a little bit. They tend to boost the brain function, make it work a little more, and people should perform better. But that doesn't stop the disease. There's several medications in the pipelines in research on clinical trials. Medications, antibodies against amyloid, against tau, and other things that are being tested. We are crossing our fingers. We're hoping that these work. Unfortunately, in the last 20, 30 years, the trials that have been done have not been promising. But the science is evolving. Things are getting better. We're getting more fancy in how we use this medication, and the very important thing is also to start using the treatments early. This is so important. It's important to detect this disease as early as possible. So it's very important to have these type of communications like we're having today to inform the population that as soon as you notice something, come to us, go to the neurologist, go to the primary doctor, because the early we catch these things, the better chances we have to do something.
Is that what you would recommend to a family member who's having serious issues with memory? Go to the neurologist, go to your primary care doctor?
Yes, hopefully before the issues get serious. There is a difference between the normal forgetfulness and the Alzheimer's type of forgetfulness. But people it's difficult even for us professionals. It's difficult to discern to distinguish between these two. So if there's any doubt, I'd rather have anybody come to us, come to the doctor, and investigate.
Now, are men more prone to Alzheimer's than women?
Well, currently the figures are getting very close to each other. So it's been a trend that it's like a 3-to-2 ratio between women and men, but it's getting there. We've never found out why women tend to have a little bit more than men. There's question about hormonal changes and so forth, but it has been a little murky territory.
We're about finished with our time with you today, so we were just wondering in closing if there's something that you would just want to emphasize to our listening audience, whether they're struggling with these issues themselves or they have a family member who is there another bit of counsel that you'd like to leave us with today, Dr. Giliberto?
Yes, so as I mentioned, it is very, very important not to hide this under the carpet and just ask for help and seek guidance. It is very, very important because it doesn't necessarily have to be Alzheimer's. It can be something that we can treat. And that is my first objective when I see a patient. Can I find a treatable cause of the memory problems or the cognitive problem? And, for example, sleep apnea is a major disruptor of memory and is a risk factor for stroke. So I ask the question about sleep all the time. So there's many things that we can find that can be treated and are not Alzheimer's. So that is very, very important. The second aspect is family support. If there's somebody that has a family member affected by Alzheimer's, they know this. They know how strenuous and extensive it is to care for them. And the stress that caregivers are undertaking every day is huge. The expenses they go through, the lack of work that they have to undergo is incredible. So society has to start asking the question, can we afford this? As you know, in a few years we'll have 15 million people affected by Alzheimer's in the United States. There must be some social policies put in place to help the caregivers take care of their loved ones, because this is getting to an endemic proportion and we're not going to be able to afford this anymore.
That's great.
Yeah, that's great.
Thank you.
Our time has come to a close here, unfortunately. We're just getting wound up. We'll have to have you come back again, but we really want to thank you. Our guest is neurologist Dr. Luca Giliberto from the Northwell Health Center on the detection, treatment, and prevention of Alzheimer's disease for joining us today. This discussion has been so interesting and informative. Again, we'd like to maybe continue this at some time.
Absolutely.
If you want to get more information, the Feinstein Institute, the Alzheimer's Division, is available to the public, and here's a number, 516-562-3492. Phone that number for general and specific information, how to handle the problem with yourself or a relative. And again, we want to thank you, Doctor. This has been so informative.
Thank you so much.
It's been a pleasure.
Yes. I'm Lamar Stanford, along with my wife, Patricia Stanford. This show has been available as a podcast on iTunes, Android Podcasts, Spotify, and Spreaker.com. If you have any comments, email them to us at any time at WHPC@ncc.edu. Thank you for listening to the Boomer Buzz here on the Voice of NASA Community College, 90.3 WHPC.